Howdy everybody, welcome back to MSK. My name is Jonathan and today we are going over another terminal branch of the brachial plexus, the ulnar nerve. Let's hop into it. So let's start with our brachial plexus roadmap and discuss how we get to the ulnar nerve from the nerve roots. We're going to have C8 and T1 joined together to form the inferior trunk, which will then go onward to become the medial cord and thus contribute to the ulnar nerve. So as we just went over, the nerve roots for the ulnar nerve are not too complicated, as we have C8 and T1 leading into the ulnar nerve. All right, let's move on and talk about the motor innervation of the ulnar nerve. We'll start with the flexor carpi ulnaris, or the FCU, as I have it written here. And this muscle will be a flexor of the forearm and shown here marked out in red. The flexor carpi ulnaris will have an origin on the medial epicondyle of the humerus, as well as the proximal part of the ulna. The FCU will then go down the medial side of the forearm and insert onto the bones of the hand, the pisiform and hamate, in addition to the base of the fifth metacarpal bone. Because the FCU crosses the wrist joint in front, we know that it will contribute to wrist flexion, and because it is so medial, it will contribute to wrist adduction in addition to flexion. So because the FCU will be on the ulnar side of the forearm, it will contribute to wrist flexion and wrist adduction. Additionally, the ulnar nerve will innervate the medial half of the flexor digitorum profundus. And so recall that the flexor digitorum profundus is a flexor that will send a tendon to the distal phalange of the forefingers, excluding the thumb. And so the medial or the ulnar side of this muscle, the flexor digitorum profundus, will be innervated by the ulnar nerve, while the lateral side of the flexor digitorum profundus will be innervated by the median nerve, which I'll represent here with blue. And so because the FDP will insert all the way onto the distal phalanges, it will contribute to flexion of the fourth and fifth digits innervated by the ulnar nerve. And lastly, the ulnar nerve will innervate the intrinsic muscles of the hand that are not innervated by the median nerve. So the hand will have its own chapter, but let's briefly go over some of the muscles and innervations so that we can parse out the differences between median and ulnar nerve. So the median nerve will be predominantly responsible for the thenar compartment, including abductor pollicis, flexor pollicis brevis, and opponens pollicis brevis. The caveat to this is that the flexor pollicis brevis has a superficial head innervated by the median nerve, but the deep head is innervated by the ulnar nerve. The ulnar nerve will be responsible for the rest of this mnemonic, with the adductor pollicis brevis, opponens digiti minimi, flexor digiti minimi, and abductor digiti minimi. While we're here, let's talk a little bit about the action of some of the muscles innervated by the ulnar nerve. Adductor pollicis brevis will contribute to thumb adduction, a motion that looks like this. So we're going to adduct the thumb closer to the palm of the hand. Opponens digiti minimi will assist with opposition of the pinky finger, the motion of bringing the pinky and thumb together, or alone the pinky moving across the hand. Flexor digiti minimi will help with flexion of the pinky, a motion that looks like this, flexing the pinky down. And abductor digiti minimi, as you can guess, abducts the pinky away from the other fingers, a motion that would be like this, abduct away, abduct away. Here I'll also talk briefly about the lumbricals, which is another group of muscles split by the ulnar and median nerve. The first two lumbricals will be innervated by the median nerve, while the third and fourth lumbricals will be innervated by the ulnar nerve. And as a reminder, the lumbricals will cause extension at the proximal and distal interphalangeal joints and flexion at the metacarpal phalangeal joints, leading us with this. But recall, only the third and fourth lumbricals will be innervated by the ulnar nerve. That might look like this. In addition to the hypothenar and thenar compartments of the hand, there are also the palmar and dorsal interosseous muscles, both of which are innervated by the ulnar nerve. Down here, we have our dorsal interossei muscles, which will be responsible for abduction of the fingers. So our fingers will abduct away from the midline. Also innervated by the ulnar nerve are the palmar interossei muscles, which will adduct the fingers back together. Adduction, abduction, adduction. And so in this image here, we'll have the opponens digiti minimi and adductor pollicis innervated by the ulnar nerve, with the opponens pollicis and abductor pollicis brevis innervated by the median nerve, and the flexor pollicis brevis with dual innervation. And I will also briefly mention that because the ulnar nerve innervates the third and fourth lumbricals, Distal injury to the ulnar nerve, which impairs those lumbricals, can lead to something called ulnar claw. So if a patient comes in with ulnar nerve injury in their hands at rest and we ask them to extend their fingers, the lumbricals acting at this joint won't be able to extend the fingers, only the other two. And so the patient will look something like this after being asked to extend all of their fingers from a closed fist. All right, let's move on and talk about the sensory innervation of the ulnar nerve. This innervation is pretty straightforward as it covers the medial hand and 1.5 digits, including both the palmar and dorsal aspect. And so down here we can see that the ring finger will be split down the middle, while the pinky and medial hand will be innervated by the ulnar nerve. All right, and finally, let's talk about causes of injury to the ulnar nerve. One potential cause of ulnar nerve injury would be a fracture at the hook of hamate, which is one of the bones in the hand. This can happen from a patient falling on an outstretched hand. It can also happen in athletes that are playing a sport that requires gripping something, either hockey or baseball or golf. As when you're holding an object, it can put pressure on the hamate and a traumatic incident can cause a fracture there. Additionally, ulnar nerve damage can be caused by a fracture at the medial epicondyle of the humerus. This is typically found in children, often from a traumatic incident of playing sports. And finally, compression of the nerve can lead to damage. So as the ulnar nerve goes to enter the hand to innervate some of the muscles and sensory innervation, it will pass through what's known as the tunnel of K.A.N. or K.A.N. canal. If there's chronic compression through that canal, that can lead to K.A.N. canal syndrome, something we often see in bikers as they're resting their hand on their handlebars for long periods of time. Additionally, there can be compression in the cubital tunnel of the elbow. This would lead to cubital tunnel syndrome. It might be the result of leaning on your elbow for long periods of time or a traumatic blow to the elbow. And lastly, there can be compression from any sort of growth or a tumor, or very often a ganglion cyst, which we would see in older patients. All right, we went over a lot, so let's recap and then we'll do a practice question together. The nerve roots of the ulnar nerve are going to start from C8 and T1 to form the inferior trunk and then go on to form the ulnar nerve. The motor innervation of the ulnar nerve will include the FCU, the flexor carpi ulnaris, in addition to the medial half of the flexor digitorum profundus, and the intrinsic muscles of the hand that are not innervated by the median nerve. This will include the dorsal and palmar interosseous muscles, in addition to the third and fourth lumbricals, the hypothenar compartment, the adductor pollicis brevis, and palmaris brevis, a weak flexor of the wrist. The sensory innervation of the ulnar nerve will include the medial hand and 1.5 digits, and causes of injury can include a fracture of the hook of hamate or fracture at the medial epicondyle of the humerus, or compression of the nerve, either through the K.A.N. canal, the cubital tunnel, or anywhere along the ulnar nerve from a cyst or tumor. And a practice question might sound something like this. A 34-year-old male presents to the primary care clinic with 1 week of new onset left-handed weakness. The patient denies trauma, but reports that symptoms worsen when holding his cell phone up to his ear for a long call or when resting his elbow on his office chair for extended periods of time. The patient's vital signs are within normal limits, and he reports that he is otherwise healthy. On physical exam, the patient has reduced sensation in the 4th and 5th digits, in addition to 4 out of 5 grip strength in the left hand. Which anatomical structure is most likely compressing the nerve leading to this patient's symptoms? Because we see reduced sensation in those 4th and 5th fingers, in addition to weakened grip strength, we suspect that there's ulnar nerve damage. And because this patient has worsening symptoms with flexion of his elbow or resting on his elbow, we can assume that there's compression in the cubital tunnel of this patient. If it instead had been compression in the K.A.N. tunnel, there would be more indication as to why there's compression on his wrist. Maybe he's a biker, maybe he's a construction worker who works with a jackhammer. But because his symptoms are worsened by actions at the cubital tunnel, we suspect cubital tunnel syndrome. All right, that's everything from me today. Thanks for watching. I'll see you next time, and good luck studying.